is a non-inferiority trial the correct way to design a study that you're looking at everybody?
Was non-inferior to blood thinners for people not at a high risk of bleeding from blood thinners. Their endpoint was not just stroke, but a combination of cardiovascular death from cardiovascular causes, stroke, and other blood clot. And at the end of this study, they found that there was no difference in this composite endpoint between the groups that got the procedure versus the group that got the blood thinners.
So I got to tell you that managing anticoagulation, like managing blood thinners, not the easiest thing in the world, right? And so I find that top line conclusion very attractive. I think ultimately what I'm thinking is that I am worried that it's not as wonderful as it seems. So that's why I want more information.
Welcome to Only Oncologists in the building. I am Dr. Shalan Beg, and I'm joined by Dr. Shruti Patel and Dr. Emil Liu. An irregular heartbeat, a fluttering in the chest, palpitations that come and go. Sometimes they're subtle, sometimes they can be pretty severe, and it takes you to the emergency department. The most common cause for that is an abnormal rhythm of the heart known as atrial fibrillation. This affects 1 to 3 adults in the United States above the age of 45. So that's about 3 to 5 million individuals who are affected by atrial fibrillation or may be affected by atrial fibrillation in their lifetimes. One of the most dreaded complications of atrial fibrillation is actually a stroke, where the irregular heartbeat can cause a blood clot to form in the heart and travel to the brain and cause an infarct in the brain and lead to problems. So for the longest time, the treatment that we've been offering people with atrial fibrillation to prevent the dreaded complication of stroke is a blood thinner. And these treatments have been offered to folks with atrial fibrillation for many decades. We've made a lot of progress on the type of blood thinners. We used to use a medicine called Warfarin, and now there are newer medications or DOACs, which are direct oral anticoagulants that are offered to individuals to reduce the chance of clot. But it turns out when you think about how the blood clot is formed, most of the blood clots are formed in a very specific part of the heart. It's known as the left atrial appendage. And I like to think about it like a little cul-de-sac in the corner of the heart. So when the heart isn't beating regularly, the blood flow becomes irregular, it becomes at a higher risk for forming a clot. And when that clot forms, that clot can travel and go to other parts of the body. So a bunch of very intelligent cardiologists and surgeons are like, what if we block that cul-de-sac and prevent the blood from collecting in that area? And it turned out that when you occlude the left atrial appendage, either surgically or through a percutaneous procedure called the WATCHMAN Procedure, you actually reduce the chance of stroke. For many years, this minimally invasive surgical procedure or this percutaneous surgical procedure has been offered to people who are not candidates for blood thinner, an older individual, someone at risk of falling, someone who can't tolerate, someone at risk for bleeding. But a recent study came out called the CIRCULATE Atrial Fibrillation study and was published in the New England Journal of Medicine that looked at whether left atrial appendage closure was non-inferior to blood thinners for people not at a high risk of bleeding from blood thinners. So we're going to get into this, thoughts on this disease and this problem from my colleagues.
So I would say there's a very real problem. I think we come across it frequently, right? People have atrial fibrillation. They're not, I would say, what we come across more frequently, though, is they're not DOAC candidates. They're not anticoagulation candidates. There's some bleed risk. In oncology, we are putting them possibly on a drug that increases their bleed risk. And we don't really want them to be on a blood thinner that's going to cause them to bleed really quickly. And so I think the idea is very intriguing from my end of just like, oh, if I could keep one of my patients who has metastatic colorectal cancer, who develops a new atrial fibrillation off of blood thinner, I'm intrigued.
I agree. For so long or for decades, it was just the default. So we all learned in residency, right? So atrial fibrillation, you have a fluttering of the heart, increase the chance that a blood clot will form and pop off and flow to other parts of the body and cause those strokes and other things that we don't want to see. But just questioning the idea in studies like this and other follow-up ones from the last few years that have been reported, this concept of how do you get away without having to thin the blood? It's really a central question. In the last few decades, we've seen the the maturation from warfarin, which itself wasn't a truly expensive drug, but the management of it required people to come in for blood draws physically into the clinic, and that caused a little more financial toxicity, but also just the chance that there was too much fluctuation in how thin the blood was. It had become overly thin, increased the chances that people could bleed excessively from the medication, and tended to block the blood clot that was at risk of forming because of atrial fibrillation. But with the maturation hand in hand, and people know us as oncologists, and we know that cancer increases the risk of blood clots, but atrial fibrillation and other cardiovascular things very separate from cancer also require blood thinning or consideration of blood thinning. That is an issue here, but I think the central strategy here is how do we get away, or what patients might be able to get away satisfactorily without having to have blood thinning medications is really important because of all the bleeding risks.
So that's why they did the CIRCULATE-AF trial. So this was published by Dr. Doshi and his colleagues in March of 2026 in the New England Journal of Medicine. The investigators enrolled about 1,500 people. The investigators enrolled 3,000 people onto this clinical trial, and they were randomized 1-to-1 to either left atrial appendage closure or the anticoagulation group with direct oral anticoagulants. The mean age of patients was 71, so a fairly older group of individuals. They had consistent risk of blood clots using a specific scoring tool. Their endpoint was not just stroke, but a combination of cardiovascular death from cardiovascular causes, stroke, and other blood clots. And at the end of this study, they found that there was no difference in this composite endpoint between the groups that got the procedure versus the group that got the blood thinners. So that raises a lot of questions. And I think for a lot of folks who are coming into the study with their own perspective, they're viewing these results their own way. What do you guys think is your major take home from this clinical trial in terms of its effectiveness, showing that a surgical procedure, a mini surgical procedure, isn't inferior to taking blood thinners for the rest of your life?
So I got to tell you that managing anticoagulation, like managing blood thinners, not the easiest thing in the world, right? And so I find that top line conclusion very attractive, right? You could just do a mini surgical procedure, which we do a lot in our patients, quick one day. They come in, I'm assuming in the morning and leave that evening, and you can save them from a lifelong of being on blood thinners, and people, it's not easy. I'm thinking about my young patients also. It's not easy to be on blood thinners, right? You can't do certain contact sports. There's certain things in life that you aren't able to do. And so, being able to say that, the risk of stroke and all of those things is similar is very attractive. Now, I have a million questions, which I'm sure you're going to help us answer, which is there are other reasons that our patients, specifically cancer patients, get clots. And I know they included deaths from clots, but kind of what were the other clot formation? Because I think that someone being on a blood thinner for AFib is also going to protect them from other kinds of clots and a lung clot and all of those things. And so I would be really curious about that. I'm also curious about you're putting a device in the heart. So I mean, it's not, I'm thinking of it as a casual port procedure, similar to a port where you just kind of go in and you do a day procedure, but it's what are the long-term effects? So how long did they look at? I think ultimately what I'm thinking is that I am worried that it's not as wonderful as it seems. So that's why I want more information. I'm excited about it, but I want to understand kind of what are the other endpoints that they looked at that compared these two. That's what I would say.
Yeah, to pick up on where you're at. So I'll provide some counterpoints, but I guess some questions are maybe time will tell. Is this a one-time procedure? Is a closure effective enough? I think all these procedures, and just for our audience that have ever heard of the terms cardiac catheterization or similar, where you're laying down on your back and a catheter is snaked through vein, the femoral vein in your groin area, and that's how they get up to the heart. It's a very interesting technology done by electrophysiologists or cardiologists who are trained in other very similar procedures as that. So the first thing they had to do was to basically look down to examine the valves of the heart and the area of the heart through a procedure. It basically uses ultrasound, transesophageal, like a cardiogram, but they had to prove first that there is no existent clot. But right, that's a moment in time. So you're trying to prevent future clots. You're trying to prove before you do this procedure that's, I guess, built to last as a one-time procedure, but I guess time will tell. But there is no clot there in the first place, but doesn't guarantee that clots won't form in the future, and then have bearing on that. But I guess I think Shalani, you mentioned non-inferiority trial, a few minutes ago, and I think it's important to understand, like in the terminology we use in clinical trials and how they're designed. There are trials designed to determine or answer the question: is some procedure or some drug or combination of drugs better than what exists? Or non-inferiority, sometimes when I explain it to patients, or honestly just try to sort through it in my own head, is it not worse than what exists currently? So in other words, you're not doing any harm by doing this, but potential benefit by, in this example, sparing someone of blood thinning medications that might have risks and side effects. So, I think it's something where there's a certain part of the population that may benefit, and who do we think in medicine as doctors are at most risk of being on blood thinning medications? We think of people who are in fragile states, so that they tend to be older. The elderly population more prone to risks and falls, and I think in my own practice when I'm prescribing a blood thinning medication, I always think in risks and balances. If this person is prone to falling, and they fractured a hip and then bled into that bone, that would be worse. That could potentially lead to death. So in that case, maybe those are patients that you wouldn't prescribe blood thinning medications for atrial fibrillation. I mean, you want to spare of blood thinning medications in that case.
I think it's important, though, to note, Emil, that this population was not those older, frail, not great DOAC candidates, right? And so one question, you bring up non-inferiority. And so one question is a non-inferiority trial the correct way to design a study that you're looking at everybody, right? You're looking at like our young, 38-year-old with, right, who develops AFib on cancer treatment, or, something like that. Even them, they have other comorbidities, but I'm maybe just a random 38-year-old with no other comorbidities other than the atrial fibrillation. And is a non-inferiority trial the right? I'm thinking about it,
Yeah. No, I think it's part of the right questions to ask. At face value, maybe I'll first start by arguing yes, because otherwise, take your 38-year-old patient, for example. Otherwise, I guess per standard practice for going back to the 20th century, they'd be committed to lifelong blood thinning medication, anticoagulation, right? Otherwise, unless there's an alternative, in this case, a procedure to seal it off that would basically replace. So if you say non-inferiority, and the conclusion is this isn't any worse, it's not going to be any worse than, and potentially, but we're not going to answer it here in this trial, better than, but definitely not worse than, that may not be a bad thing for the 38-year-old who otherwise just wants to live a healthy lifestyle. They want to go running. They want to do things without having to be on blood thinning medications. Although it will just say for the DOACs, the medications they are prescribed by physicians, but unlike the older type of medications, the current class doesn't require blood draws multiple times per week or multiple times per month to make sure that the levels aren't fluctuating too wildly. They're very more targeted in terms of their blood thinning capabilities, but still, I think of it like sparing, like addition by subtraction. Do the procedure.
You're saying you're a blood thinning hater, is what you're saying. You're saying you're a blood thinner,
I guess.
Hater.
So what we're talking about is actually is really where the cardiology community seems to be conflicted. I think there's very little. Now, just to continue on Emil's point, this is not just you put a catheter into an artery in the leg and thread it into the heart. You have to get into the heart, then you pierce the septum that separates the left and the right part of the heart. You pierce that to get onto the left side, and then deploy the device. So there is a risk of bleeding. There's a risk of a complication called a pericardial effusion, where blood can collect around the heart. There's a risk of that device migrating either within the first 24 hours or during the lifetime of the individual. They need to be on blood thinners for 45 days and antiplatelet therapy for the rest of their lives. It's not like they're just go scot-free without any specific medications. So there are two groups of people here. One group of people are the folks who are at a high risk for blood thinners. And I think the community and even our conversation is saying for that individual who is not a good candidate for a blood thinner for the many different reasons that we're talking about, probably the procedure is going to be less burdensome and safe and more effective. But let's now move to people who are not a high risk for blood thinners. You're introducing the risk of they're calling it minimally invasive procedure. I guess technically it is a minimally invasive procedure, but it is a real procedure. You are on blood thinners. You require a transesophageal echocardiogram before the procedure, and then multiple times after the procedure to make sure the device is still in place and hasn't migrated, hasn't caused complications. The risk of significant side effects, significant complications from this procedure is between 7 and 10%.
Okay.
Some of that could be early, some of that could be later. And when we think about introducing this device into individuals who would do quote unquote just fine with a blood thinner, the way we look at this is really different. So when I think about any surgical procedure, at least the way my oncology brain has been trained, is if you're doing a surgical procedure, it has to be better. So in this study, they decided to use they did two things with the endpoint. The first is they said, we're not only going to look at stroke, we're also going to look at cardiovascular death and other blood clots. So in my opinion, that dilutes the impact of studying the stroke because you're now including other endpoints as well, which isn't just the most dreaded one in this scenario. And the second thing is they use a non-inferiority trial. And a word on non-inferiority trial is when you decide a non-inferiority trial, you're saying that you're offering two different regimens and they're going to fall within the same range. So you give a little bit of leeway for it to be better and a little bit leeway for it to be worse. And you design the study and say, hey, if both of them fall in the same range, they're pretty much equivalent. Now, what happened in this study were two things. First of all, we used a non-inferiority design for a procedure. So that was a little novel. The second bit is the assumption that they made in terms of the number of side effects that they're going to see turned out to be incorrect because they saw much fewer complications and much fewer endpoints of stroke, cardiovascular death, and blood clot in this trial compared to what they were anticipating. So imagine you're running a 500-meter dash and you're like, we're all going to end at the 500-meter. And as long as both of the runners end up within the same range, we'll consider them equivalent. So maybe one ends up ahead, maybe one ends up behind, but as long as they're within this one range, it'll be fine. And you start the race, and later you realize that the ending of the race wasn't really at 500 meters, it was at 100 meters. And now you're seeing that one of those may be numerically higher than the other. What do you do with the results? And that's the situation that we're in right now, which is making sort of the purists and the academics really challenge the results and whether this was the correct study to do for this patient population.
Right. I think it's a good point, especially because you're having two different modalities, procedure versus medication. And there's a little bit of apples and oranges mixing there. And
I really liked your point about the aggregate of the blood clots, the cardiovascular disease, and the stroke, because the idea is if you're blocking the atrial appendage, right, what that is supposed to reduce is stroke, right? That's the idea. There's not a clot there, that it doesn't get sent up to the brain. I think even clot-related death I could get behind including, but the cardiovascular disease endpoint I would challenge. I don't know what that really adds to the study in terms of like, are you actually testing an endpoint that was changed by your intervention? And so I'm like glad you pointed that out because that makes me pause a little bit. And then but I also think that to the point of having options, right, is valuable, I think. I think some people do not want to be on a blood thinner forever. Now, do I wish perhaps that maybe the trial was designed a little bit differently so we could have asked a question, what's better? Yes, of course. But, there's a reason, even in oncology, right? We have multiple ALK inhibitors. We have, and I'm not saying that's always the best way to do things, but there's an argument to be made. Some people say it's hurting. Some people say having options helps the market and it helps people have choices, because the reality is side effects of these two very different, because it's apples to oranges, the side effects of the apple and the orange are very different, and what they have to go through is very different. And so I think um, I think it's valuable to have options, I guess, is what I'm trying to say.
Yeah, yeah. We talk about medication adherence all the time, and it just makes me wonder if someone's, to go back to your 38-year-old example, Shruti, like, if someone's not usually on medications, and, as you said, Shalon, it's not that they're scot-free. They will have to take some kind of other types of medications. But if you're not used to taking it, I wonder what the medication adherence is like, as opposed to someone who routinely has to take medications. That's just one more pill. It's almost like, well, what's the difference? But talking also about the device and the longer term complications about it, right? So any device can migrate, right? It's a foreign body, and there's a growing of the kind of the internal skin of the blood vessels that we call endothelialization, right? So it grows over that, and that takes weeks or months. But then if you have a device that's inserted as part of a closure, right? In this case, like in this procedure, you in any part, whether it's in the bile duct or other things that we also see in oncology, but they have a chance to migrate, so they can move. And so where would the left atrial appendage closure device move? Into the bloodstream, and so our pumps our blood throughout our body. So just what are the risks and side effects of that? I imagine the investigators will probably report on that in the longer term follow-up studies from this, but it's something to consider as well, as compared to doing a blood thinning medication where you don't have a foreign device.
Yeah, and I think we can probably wrap up on this point on whether left atrial appendage occlusion should be an option for people who otherwise are a decent candidate for blood thinners, and whether having options is necessarily always a good thing or not. Coming from the oncology standpoint, coming from the patient advocacy perspective, why would having more options ever be a bad thing? Well, it could be a bad thing if both of the options are not being explained to the individual in the correct manner. It could be a bad thing if the study that was done was performed in a biased manner, sponsored by someone who is inclined towards having the result be in a specific way. And if we lose this conversation at the bedside, if we lose this conversation in the professional discourse, we're doing the field and we're doing our patients a disservice. From my opinion, the study could have chosen their endpoints a little differently, and they really should have been forced to have a superiority design for this group of individuals who otherwise have had a fairly decent option in terms of blood thinners available to themselves. Final thoughts from you all.
I think that I agree that they could have designed the study better, but I do think it's nice that there is an option. Again, that being said, of course, talking to your patients and having that discourse, which is sometimes, I recognize, hard in the clinic, but really outlining the benefits and risks of both is extremely important. But and I hear the concerns, and I knowing that the study was funded by the by the company is good to know, and would definitely makes me question it a little bit. But at the same time, I think because we're comparing apples to oranges, I think having options in different ways, where one's a one-time procedure and one's a daily pill, I think it's valuable.
Yeah, I think I absolutely hate the term when anything quote is here to stay. But I think whether we like the design or we know the limitations or not, I think the introduction of this, just because it's published in New England Journal of Medicine, doesn't mean it's outstanding or true. But for that matter, it's here to stay in the sense that it's going to be presented as an option, whether we agree with it or anyone else in the field agrees with it or not. So I think you're exactly right. I think both of you, and it's how it's presented to patients as a potential option. There are other similar trials using the same strategy, the left atrial appendage closure in older population. I think that was called CLOSURE-AF. I was just referring just to make sure I got the name of that trial correct. But I think whether it's our younger, young adult patients or older patients, it's something that's going to be offered. And so carefully weighing the risk versus benefits and just understanding how the trial was designed, what limitations it may have, what conflicts of interest we should always consider and put on the table very openly, and saying how that colors the conclusions made, even if the data are true, however you want to state that, really have to be taken into consideration. So I hope that however it's offered, it's done in a more balanced manner, or as effectively as possible.
Wise words. Thank you very much. That's all the time we have for today. Thank you, Dr. Patel. Thank you, Dr. Liu. And that's all from us for today.